children that we are having a session on pediatrics for the first time. We're going to have two people. One is Aaron Turkish from New York Hospital Queens, who's a gastroenterologist, who's going to talk about pediatric nutrition and to some extent gastroenterology. And then followed by J.B. Gunn, who lives in the community, who practices in Brooklyn and is well aware of the immunization problems there. And he's going to be speaking about immunizations. At that time also, I will be happy to, I won't speak, but I'll be happy to answer any questions about adult immunizations, but give me 2 weeks to check up on it again. First speaker tonight is somebody who I share an office with. He is the director of the cardiology coronary care unit at New York Hospital Queens. If you don't listen to his advice and end up having a heart attack and Hatzalah takes you to a hospital, you will meet him. Please don't meet him that way. Meet him tonight. Dr. Emmanuel Moustakakis.
Thank you very much, Mel, and thank you very much, everybody, for coming out tonight. And it's getting pretty cold. Can you guys hear me better without the microphone, or do you prefer the microphone?
Doesn't it? Prefer no.
Mike.
Prefer, okay.
Without them.
Prefer without?
I prefer without, but it's not up to me.
All right.
I think the mic is better.
Let's try it for a minute without. I tend to speak pretty loud anyway, so if you guys can't hear me and you want me to go back to the mic, then just stop and let me know. Like Mel said, I'm an interventional cardiologist at New York Hospital Queens. I'm on the full-time faculty there, so I have a lot of different roles. But one of the main things that I do as an interventionist and as the director of the coronary care unit is I take care of patients having heart attacks, which is a pretty busy job most of the time. Tonight, I'm going to try and keep this at about like 30 minutes so that we leave time for our next speaker and leave time for questions and plenty of time for discussion later on. But basically what I want to focus on is a discussion about the risk factors for coronary artery disease and heart attacks in general, and how you recognize them, and sort of what people can do, whether it's by your own as a lay person or in discussion with your physician about how you can manage your risk factors and recognize risk factors for heart disease. And then that's going to segue into the next discussion, which is basically about our rehab center, I think, and exercise in general. And a lot of our heart attack patients come over at our rehab center and they've done very well. So let's just jump right in. This is not relevant here, but in general we're going to talk about what is cardiovascular disease and what is atherosclerosis, and then what is the magnitude of the problem. We're going to talk about the risk factors for developing heart disease, and then sort of what you can do to minimize your risk, and God forbid, if you do end up with one of these syndromes, how you can sort of recognize the symptoms and signs of a heart attack and heart disease in general, because recognition is critical. So I'm going to skip through a lot of this kind of technical stuff just in the interest of time. But basically this is a healthy looking artery. This is in cross section, but this is a healthy looking coronary artery. It's nice and it's smooth. Now here, this is not so nice and not so smooth, and you can see a lot of kind of cholesterol deposits and build up in the walls here. And this is what we're trying to prevent. And there's a lot of things that we can do to recognize this problem and to prevent this problem. And this is what we're really trying to prevent. This is what I do for a living. This is when a blood clot is formed because one of those plaques is ruptured. And this is basically how heart attacks happen. I want to emphasize a few main points, but one of the first points that I want to emphasize is that this is not something that happens to us when we're 80 years old. This is basically a lifelong process through a lot of adulthood, the development of atherosclerotic plaques and the development of heart disease in general. You can see that we know that plaque starts to build up even from the first few decades of life, and certainly the first couple of decades of adulthood, and really progress for a long time, several decades. This is a decades-long process before some unfortunate few will have the plaque rupture and the heart attack and the progression to more severe disease. I think I don't really probably have to tell most people that the magnitude of this problem is pretty impressive. Heart disease across all spectra of adulthood, males, females, young, old, is by far and away the #1 killer in most of pretty much the whole civilized world, certainly in the western part of the world and in this country for sure. But I think what I want to point out with this slide here is that if you look at the red is heart disease. And if we're talking about hundreds of thousands of deaths annually, this is a little bit of a dated slide from 2004, but I promise that the more updated ones look pretty much the same. This does not change that much. If you look at heart disease in all ages, basically the deaths are going to exceed the deaths from a lot of other things combined, but whether you're talking about a young population or a much older population, the trend persists. This is basically an equal opportunity killer that kills across all age groups. If you look at men and women, this is the percent of the population that develops atherosclerotic disease, which is sort of the fancy way of saying plaque in the arteries of the heart, significant coronary artery blockages. I think we all probably understand, it's not a stretch to understand that a lot of people, as we get into a much older population, are going to have some evidence of plaque and certainly the presence of risk factors. This data includes heart disease, heart failure, stroke, and hypertension, but I want you to pay attention to kind of these groups down here. I think we tend to think of heart disease in general as an older person's problem, but I want to assure you that it is very much a younger person's problem as well. I've seen a relative few, a small handful of people in their 20s and 30s that have had heart attacks that end up on my cath table. Obviously, the bulk of this 15% of men in their 20s and 30s is going to be represented by high blood pressure, but bear in mind that I want to emphasize that this is a disease process across the entire spectrum of age. It's, again, my number one concern is not always so much about the expenditure and what it's costing our government, but obviously there's a lot of different facets that are very important. A lot of public health policy is driven by this problem. In this country, we spend about $200 billion a year on heart disease, and unfortunately only about 6% of it is spent on prevention, which is where I wish we would spend a lot more of it, because you do a lot more good for people by preventing a heart attack than by me coming in and having to stent you after the damage is partly done. So let's jump ahead to the risk factors for heart disease, and I think that's really where I want to spend the bulk of the discussion over the next several minutes, because that's really what I think most of the lay public and people that come to these kinds of programs, that's what you're interested in. What are the risk factors? What are the things we can do things about? What are the things we can't do anything about? And when we talk about the risk factors for heart disease, we're talking basically about two different groups. We're talking about the modifiable and the so-called non-modifiable. Modifiable just means you can do something about it. So things like smoking, or you can quit smoking. Now, some people it's easier to quit than others, but technically that is something that's a behavior that can be changed. Hypertension, high cholesterol, diabetes, obesity, these are all things that can be modified, whether that's by medications, whether that's by lifestyle changes, dieting, exercise, and so forth, the sedentary lifestyle. These are all major risk factors for the development of heart disease, and certainly far and away in red, smoking is number one. The non-modifiable, that means things we can't do anything about. Well, we can't pick who our parents are, okay? There is no doubt that there is a certain genetic component. We understand a lot of things about genetics in cardiology, but we don't understand everything, to be sure. And so it's pretty clear that there is genetic variability in the way that people metabolize cholesterol and the way that people deposit cholesterol in the arteries of their hearts. Some people have terrible diets, have very high cholesterol. You look at their coronary arteries and they look pristine, clean as a whistle. Other people doing all the right things, they have very low cholesterol, they exercise, they just happen to have bad genes passed on from one or both of their parents, and they tend to form aggressive disease. Can't do anything about the parents that we have. We can't do anything about the aging process. If we all live long enough, we're all going to get older. And at a certain point, being older certainly is a risk factor for heart disease. Older people, it's much more prevalent than younger people. And the question mark about diabetes, diabetes really falls into both. Diabetes is a major risk factor for heart disease. The non-modifiable part is the type 1 diabetic. If you were born with a pancreas that doesn't make insulin, there's not really anything you can do about that. You just have to take insulin injections. This is a graph that basically shows that these four traditional risk factors that we'll talk about account for over 80% of the cases of coronary artery disease each year. And they are basically high cholesterol, high blood pressure, diabetes of typically of type 2 variety, and cigarette smoking. And if you think about over 80% of the heart disease mortality every year can be attributed to one or more of these risk factors, I want to really emphasize and draw your attention to what is it about these four that is really significant. Well, it's the fact that all four are modifiable. So there are things that people can do to really affect all four of these things, and obviously affecting any one or more of these things could dramatically impact the mortality from heart disease. So let's talk a little bit about each risk factor by itself and sort of get an idea of what it is that we can do, how we can recognize the risk factors, and what it is we can do to modify them. We talk about high blood pressure. There's a little asterisk here because just recently these guidelines have finally changed, and we've been waiting on this for at least 5 or 6 years, and just a couple months ago the American College of Cardiology and the American Heart Association, along with some other societies, released some new guidelines. Historically, high blood pressure is defined as consistent readings above 140/90. The new guideline update has sort of relaxed the targets for treatment. Historically, we want to treat patients who are consistently above 140/90. Now some of those things have changed. That's where all of you got to go see Mel, and he can update you on all the guidelines, when you see him in the office to check your blood pressure and so forth. The treatment of high blood pressure, without question, reduces the risk of both the development of cardiovascular disease and of dying from cardiovascular events. So how do we, and that's true across the spectrum of all ages, whether you're 40 years old, 50 years old, 90 years old. That trend is quite clear. In terms of therapy, what do we do? Well, you'll notice the theme of lifestyle modification is prevalent throughout. There's no question that engaging in healthy lifestyle activities will reduce the possibility of developing high blood pressure, as well as reducing the risk of developing cardiovascular events. So what is lifestyle modification? Well, low sodium diet, regular aerobic activity, keeping your weight under control, those are but a few. And then certainly as a second line, drug therapy and pharmacologic therapy is available. That's well beyond the scope of this discussion. There's at least 7 or 8 or 10 classes of medications, some more commonly prescribed than others. But by and large, the treatment of high blood pressure is well studied and well established, and there's a lot of ways to be effective about that. With respect to cholesterol, it's not just a total number. I'm sure many of you are aware that there's a breakdown between good cholesterol, so-called good cholesterol, and bad cholesterol. It just has to do with the density of the lipid and how it affects the deposit of plaque in the walls of arteries, for one thing. Just a couple of definitions. LDL, or low-density lipoprotein, is the bad cholesterol. It has a lot of different components, but we'll just think of it for the purposes of tonight and right now as sort of one entity, LDL. And then HDL is the good cholesterol. The higher the good cholesterol, the better people's outcomes, and a very low good cholesterol is associated with a higher risk of developing heart disease. So this is also kind of a moving target. We have recently changed the societies have released updated guidelines for what the targets for treatment are. But historically, the focus on the treatment of LDL, as far as the new guidelines are concerned, see, it's different for people with clinical heart disease. That's who I deal with all the time. For most of my patients, they all have heart disease, and so they all have a separate indication to treat their cholesterol because they're, by definition, already in a higher risk group. For those people, you want to basically put them on a statin like Lipitor or Zocor or Crestor and reduce their cholesterol, their bad cholesterol, by at least 50%. But what about people who don't have heart disease? Well, we want to basically treat anybody whose LDL is greater than 190, any adult basically, is going to, this number is a very high number. It is associated with a higher risk of developing disease. And then particularly in diabetics, anybody who's a diabetic who has a bad cholesterol above 70, and anybody with an estimated cardiovascular risk that's on the higher side. And I won't go into the details of how this number is calculated, but this is something that pretty much any cardiologist can give you an estimate of what that risk is. And 7.5% is considered a fairly high risk of developing heart disease in 10 years. The secondary focus on the good cholesterol, for men, an acceptable number is greater than 40. For women, an acceptable number is greater than 50. How do you get a high good cholesterol? Medications aren't very good at that, but in general, regular aerobic activity is the way that you get a high level of a good cholesterol, and that is very much independently predicted to reduce your risk of heart disease. So aerobic activity, which we'll get to in a little bit, is very, very important. I'm not going to get too much into statin therapy. It tends to be a little bit of a polarizing topic because statins are one of those drugs that some people really love to hate. In general, my approach is that I think they're very safe. Certainly there is a small percentage of people who will experience some adverse effects, and we can talk about that if anybody really wants to know more about that. But in general, statin therapy, and again, these are drugs like Lipitor and Zocor and so forth, these are mainstays in the treatment of heart disease. They are, aside from lowering the level of bad cholesterol, they are proven independent of that to reduce the risk of dying from cardiovascular events in patients who have heart disease. So statins are, I prescribe them every day. They're near and dear to my heart, no pun intended. They're very much a mainstay in the treatment of virtually all coronary artery disease. So who should have their blood pressure and cholesterol checked? Very quickly, obviously, everybody. Any adult should have their blood pressure and cholesterol checked. How frequently you do it is a little bit of a moving target. It depends a little bit on your risk factor. That's going to look great on the video. It's okay. Perfect. Okay. So what about diabetes? Diabetes, a major risk factor for heart disease. It's a major risk factor for any vascular disease and a lot of other things too. It really is an awful disease process. I think probably everybody can kind of understand that diabetes is a basic inability to metabolize sugar, whether it's because your pancreas doesn't make enough insulin or your body has become resistant to insulin. It is associated with damage to many organs, everything basically from head to toe, your eyes down to the arteries in your feet. So people diabetics frequently get circulation problems in their legs, and then they're basically at risk for any manner of vascular disease, and certainly cardiovascular disease is one of them. It is markedly an independent predictor of increase in cardiovascular risk. Smoking, I cannot tell you how important it is to quit smoking. I cannot overemphasize the risk associated with smoking with respect to cardiovascular disease. It is associated with 1/2 or more of all cardiovascular events in women. This second bullet is really the point that I like to focus on in a group like this, is because I think a lot of people have been smoking most of their adult lives, and I get a lot of patients who come to me sometimes and they'll say, you know what, I understand, there's nobody who doesn't know that smoking's bad for you, right? But there's a lot of people who say, I enjoy it, I've been doing it for 40 or 50 years, what's the difference if I stop now? Well, I can't speak for all disease processes. A lot of lung disease, a lot of cancer risks, maybe that risk doesn't change so much by quitting smoking later on in life. But cardiac disease, most definitely, the risk can be mitigated at any point in life if you quit. And generally the risk to your heart dissipates within about 2 to 3 years after quitting smoking. So you could be a 70-year-old man who's been smoking for 50 plus years, and if you quit smoking today, you're risking 2 or 3 years of developing heart disease, or a heart attack or cardiovascular event from smoking will basically dissipate to that close to a non-smoker. And I think a lot of people don't know that, and if that's one of the take-homes that I can give to you tonight if you're a smoker, it's never too late to quit. The heart is a very forgiving organ that way. Lungs, not so much, but this isn't a lung discussion.
How about a secondhand smoker?
Secondhand smoke's important. Okay, it's definitely, I think, a risk factor that is increasingly been shown to, if you worked in a bar your whole life before New York City banned smoking in bars, or if you grew up in a household where both your parents were chain smokers, then yeah, there is definitely some risk involved with that. But any risk associated with smoking with respect to the heart can be mitigated by quitting. So to that end, if you do smoke, and I'm not asking for names or a show of hands, I would implore you to, as you leave tonight, kind of figure out a way to stop, because you can definitely minimize your risk, no matter how old you are, no matter how long you've been smoking. Obesity. Obesity is a staggering epidemic in this country, and I think we hear a lot about it, and sometimes we don't necessarily understand the magnitude of the problem, but I'm going to show you some maps in a minute and some charts in a minute that really, I think, underscore the importance of this problem, and it's really the best part of this presentation is coming here in just a minute. Everybody always goes ooh and ah when I show these maps. obviously obesity is an epidemic that impacts a lot of areas of just general health, and it is a public health disaster. But with respect to heart disease, the incidence of heart disease is clearly increased in people who are obese. Body mass index is a flawed metric, we understand that, but it is what we've got for the most part, and when I show you the maps, the trends are consistent despite any flaws in body mass index. With respect to diabetes, we said that's an independent risk predictor for developing heart disease. Obesity itself can, even just 10 or 20 pounds, can double your risk of diabetes, which in turn impacts your risk of heart disease. So how many people die every year? Probably about 300,000 or more deaths per year are attributed basically to obesity. So it is a problem, and it's getting worse. I'm not going to go through all of this part here, but these are the maps. So if you don't pay attention to anything else I say, pay attention to this part, because this is always a very impressive process. This is the Centers for Disease Control's maps on obesity in 1985. And these light blue and dark blue represent the percentage of a state's population that was morbidly obese, and that is to say a BMI of greater than 30. To put that in perspective, that for a 5'4" person, that's about 30 pounds overweight. The taller you are, the even more overweight. So what this is saying is, take for example in New York State, in the light blue, less than 10% of the population in 1985, less than 10% of adults were this severely overweight. The white is data wasn't being collected at that point for those states. So a lot of states hadn't reported any data yet. You'll see in 1986, 1987, you see where this trend is going. A lot of the light blue are turning into dark blue. By 1990, half of this country was dark blue, which is to say 10 to 15% were morbidly obese, severely overweight. In 1991, we needed a new blue. We needed an even darker blue because we got past 15%. Now we're getting closer to 20%. So states like West Virginia or Michigan, a couple of states in the Deep South, you're getting closer to a quarter of your population is morbidly obese. And now almost every state has reported. Here's 1995. 1995 is now is within this generation. Okay, most of us remember 1995. All of us remember 1995 very well. And you can see that light blue, less than 10%, gone. None of those states even exist anymore. Every state has at least 10%, and now a good half of this country is in the 15%. You're going to like where this is going. By 97, we needed a new color. We're out of shades of blue. Now we got to move to yellow. Pick a different color. Now we're yellow. Yellow is greater than 20%. By 2000, half of this country was morbidly obese in the 20% or more range. If you think yellow, we're going to move past yellow, I promise. Mississippi in 2001 made its own group, greater than 25%. More than 1 out of every 4 adults is morbidly obese. They've moved to orange. You can see where this is going. By 2005, remember the light blue to dark blue to even darker blue? Even darker blue didn't exist when we started. Now only 3 states are even in darker blue. And what's this? 3 states are in red. Red is greater than 30%. We're approaching 1/3 of adults in these states are morbidly obese. As we skip ahead, 2010 was just recently reported. The CDC lags a few years behind. So 2010 is the most current map that's available. You'll remember when we started, we only had these 2 little light blues over here. Now we're out of all blues entirely, and half of this country is bright red. I'm from Texas originally. Texas just joined this dark red group this year in 2010. I'm sad about that. More than 1/3 of adults in these states are morbidly obese, severely overweight, and this trend is obviously getting worse. It's a staggering epidemic, and it's a process that's getting worse in a hurry. I don't know what's going to come after dark red. Is it going to be black? I mean, maybe black is what's next. Yes, sir?
When you use the term morbidly obese and severely overweight interchangeably?
I am for these purposes. It's a little bit of that's a little bit of a loose definition, but for the purposes of tonight, I want you to understand that yes, morbidly obese and severely overweight I'm using together, but really morbidly obese is more than severely overweight.
Could you give that definition again, morbidly obese?
Morbidly obese is a BMI greater than 30, a body mass index of greater than 30, and now I can't really define that number for you, but for example, if you were to Google BMI calculator, you would just plug in your height and your weight, and it would tell you what your BMI was. Greater than 25 is considered overweight. Greater than 30 is considered morbidly obese.
Anything under 25 is okay.
Is okay. If you were much less, you would be underweight, but that's not really relevant to this discussion. It is a flawed metric because there are a relative few people out there who are just bigger people. Generally, though, unless you're a linebacker, you're not probably... I have a friend, one of my best friends is 6'4" and 205 pounds, and his BMI is right at 25. He's classified as just about overweight, and if you see him, he's tall and thin. He's in great shape. It's a little bit of a flawed metric, but with very few exceptions, anybody with a BMI over 30, unless you're a world-class football player, you're probably morbidly obese. You're probably not just a tremendous physical specimen.
And those guys become morbidly obese right after they...
As soon as they retire, yeah, as soon as they let it go, they become morbidly obese. So this is unbelievable. And so when we think about, you know, all the efforts that are going on with public health and so forth, and we see the risks involved with heart disease, and we see the public health expenditure, it's no secret that there's no money in this country. The place is going broke, and the more this happens, the more you will continue to see expenditures have to go that way, and it's just an awful problem, not to mention raises your risk for heart disease. So, what are the secrets of longevity? It's not a secret. It's really, it's all the things that we all know, and sometimes we're better about doing than others, but it's basically eating healthy, watching our weight, regular exercise, if we're able to exercise, you know, certainly quitting smoking, and then controlling these modifiable risk factors that I've discussed. All of these things reduce the risk of heart attack, stroke, diabetes, etc. Exercise, I'm not going to belabor this now because I don't want to steal the thunder, but it's good for all of these things. Certainly it's not just heart disease. It reduces the risk of colon cancer, for example. Oh, all right,
I'm kidding.
It's good. So what can you do to minimize your risk? And this is what I would talk to you about if you came to my clinic asking me these questions. This is basically what most of my clinic sessions with heart disease patients center around, is modify the modifiable risk factors. If you're a smoker, we talk about strategies to quit smoking. If you're obese, we talk about strategies to lose weight. Certainly active lifestyle, treating cholesterol, diabetes, and high blood pressure, and so forth. Hormone replacement therapy, I'll just touch on it very briefly because it was a very hot topic about 10 or 15 years ago. We've known for many years that women who are premenopausal, who still have regular menstrual cycles, they have a lower risk of heart disease. And so for a long time it was presumed that it must be estrogen that is protecting people, because as soon as they went through menopause and were no longer producing estrogen, their risk shot up to that of their male age counterparts. So for a long time we hypothesized that if we just replace the hormone, give people estrogen replacement therapy, that they would do better. Well, it turns out they did worse. They had higher rates of heart attacks and cardiovascular events. So there's no role anymore for hormone replacement therapy in older women. Or in postmenopausal women, and that's been the case for at least 10 years. Certainly there is still a role in certain breast cancers and gynecologic cancers, but for heart disease there's no role. So again, more than 80% is a big number. If you can modify your risk factors, you can lower your risk of heart attacks and heart disease in general. I'm going to wrap it up here a little bit prematurely. I'm not going to go through the rest of every slide, but I do want to pay attention to it, mostly because I want to leave time for everything else, and this was the bulk of what I wanted to discuss. But I do want to leave you all with this slide right here. Again, with respect to the magnitude of this problem, heart attacks in general represent about 1.2 million cases every year. About a third to a half of people with heart attacks will die before they reach the hospital. Some with a sudden death, some with an irregular heartbeat and a life-threatening arrhythmia, whether they're on the street, in their house, in an ambulance, or so forth. That translates to about 1 every 20 seconds and 1 death every minute in this country from an acute heart attack. If you make it to the hospital, greater than 90% chance that you will survive to hospital discharge. And that's when rehab comes into play and so forth, and people tend to do very well if you can get to the hospital. Who can get a heart attack? Any age. Certainly the risk increases with age, but half of all heart attacks occur in people who are less than 65 years old. As an interventionalist, I do balloon angioplasties on people who have heart attacks all the time. I probably do about 5 to 7 a month myself. The youngest patient I ever did was 20 years old. The oldest patient I've ever done is 96 years old. So it's not that many people in their 20s, but just to emphasize again, it really does not discriminate with respect to age. Again, we want to think about this as an old person's disease, but it really isn't. It really is a disease that spans the spectrum of age. And that's basically, I'm going to leave it at that because I think that that's kind of covered the bulk of risk factors, and I do want to leave time for the next presenter. Okay, so thank you very much for your attention, everybody. I hope that was helpful.
Anybody?
Two things maybe I'll comment on.
Okay, aspirin and learning CPR. So a couple of comments, aspirin. I would say any adult should have a regular primary care physician. I hope you all do. Somebody that you see at least once a year, even if